I want to introduce Dr. André Gervais. He's a medical consultant for the Montreal Public Health Department at the Centre Hospitalier de l'Université de Montréal. He's also associate professor of medicine at the Université de Montréal. He's been involved in tobacco control as a public health issue for the past 3 decades. He has participated in campaigns leading to the adoption of and implementation of tobacco legislations in Canada in 1997 and in Quebec in 1998, 2005 and 2015. He contributed to research in smoking cessation practices of Montreal physicians, reviews and guidelines on smoking cessation, and he was one of the authors of the Canadian Lung Association guidelines on COPD, and recently of the Montreal Public Health recommendations on the legislation of cannabis. Thank you so much for your generosity in accepting our invitation to share your expertise in the field of smoking prevention treatment. Ladies and gentlemen, Dr. André Gervais.
Thank you for inviting me. So today I will talk to you about the treatment of tobacco use and dependence. First of all, I have no conflict of interest with tobacco, e-cigarette or pharmaceutical industry. What I'll cover today, I'll review with you the proven interventions that work to help patients stop smoking. I will review the smoking cessation aids that are available. I'll talk about nicotine replacement therapy, how to use it. I will review new data on varenicline, which is Champix, in regards to neuropsychiatric risks and cardiovascular risks. And with the time that remains, I'll say a few words on Zyban, which is also a proven smoking cessation aid. In all that, I will slip in a bit of information on the e-cigarette that's now with nicotine, that's now legal in Canada. And I will leave you on resources or how to refer smokers for cessation. Well, first of all, we wouldn't be here if it wasn't for those facts. If you smoke and you start usually at the age of 12 and carry on through adulthood, you have a chance in 2 of dying from a disease caused by smoking, which is basically why we're here today. A smoker loses an average of 10 years of life expectancy. This doesn't even mention all the morbidity associated with the fact of smoking. Actually, it's more this why we're here today, because if there was nothing we could do about it, well, I wouldn't be here. But if you stop smoking between the ages of 30 and 40, you regain the almost total life expectancy. And even if you stop at 60, it's 3 to 4 years that you will gain. And that doesn't take, again, into account what happens to your morbidity, because even if you're 60 and you gain 4 years, you will decrease all the complications and a lot of morbidity if you've stopped smoking. Actually, I've summarized a few of the health benefits of quitting here. And as soon as you stop, you start having benefits because carbon monoxide levels go down in your blood, and that decreases your risk of sudden death very, very quickly. But it'll take up to 15 years to be back to normal for cardiovascular risk, but after a year, you've reduced by 50%. Lung cancer risks, even 10 years, 15 years later, will still remain not 50%, or after 15 years, you will probably be around maybe 10% of the risks of having a lung cancer. It's very difficult to stop smoking. And 70% of smokers want to stop, 45% make an attempt each year, but it's only 3 to 5% that will be non-smokers 6 to 12 months later. That means 97% have relapsed. Even after a year of not smoking, you have a 40% chance of relapse. This shows you what the abstinence rates are using different modalities to interventions to stop smoking. Population survey, as I've just said, at a year, it's about 3%. But if in control groups of randomized control trials where we have placebo versus a medication, with just support that's given in those studies, you're over 10% that will stop smoking. And that's the support alone without medications. Different medications will bring you up with a combination of a nicotine patch and a gum or a spray will bring you up to the 35% range. Varenicline alone, about 30% range. Those two are the best two smoking cessation aids that exist. Now, all those interventions work without medication, and they increase by 1.3 to 2 times the chance of stopping. Means it brings you from 10% to 20% of being abstinent about 12 months later. Physicians advise group counseling, interventions starting during hospitalization, cell phones, textos, helplines. For medications, those are randomized controlled trials here, where you have on one side patients that get support plus placebo or support plus the real medication, and we look 6 months to 12 months later at who's not smoking in both groups. You about triple with varenicline. I said it was 30% earlier, so from 10% to 30%. You see that with Zyban, which is bupropion, it about doubles, and nicotine here, patch, gum, or other types of nicotine, which we call nicotine replacement, about doubles the chance of stopping smoking. The combination, 3 times. So those two, again, stand out as the best smoking cessation aids. What's new is that you can now start the medication while you're smoking and decide after to stop smoking. And I will explain that in more detail later, but those meta-analyses were done on support for reduction of number of cigarettes smoked plus varenicline versus placebo, and you about triple your chances of stopping if you've done that. If you do it with nicotine, you about double the chance of stopping. Now, in those studies, if you use varenicline or bupropion rather than nicotine replacement, you are more likely to stop the treatment because of side effects with varenicline. And we'll talk about varenicline risks later on. My first key message, they're interventions that use a combination of smoking cessation aids and behavioral support are most efficacious. All the studies on medications were done with a rather intense support to stop smoking. And I didn't have time here to show you evidence of what happens when you use just stop medications alone. Sometimes they don't work at all. So the message here is that the support is always essential. This is as close as you come to guidelines in Canada, a paper published in 2016, and they've given a flow chart on how we should proceed. Patient should always be identified as whether he's a smoker or not. So first is to identify, and it should be done in the chart at the entrance in hospital if it's in a hospital. There should be advice right away to stop. But now we determine the goal right away, and that's where the changes have taken place. Before it was quit abruptly on the quit date. So we'd say you're going to stop that day, and we start medications after. Now we can reduce the number of cigarettes smoked and decide on a quit date that's later and start the medication. Or we can even say, well, you don't know when you're going to stop. We're going to start medications and we'll find out later. There are patients who are not going to want to do anything, and those patients are the ones you have to work on motivation. And it's summarized by the 5 R's here as to what you should do to motivate these patients. And you should see them again to help them in the process of stopping. Once you've determined which way they want to use to change their habit, you assess the patient according to his preferences, but you review the smoking history, the quitting history, the medications, of course the contraindications, and you always have to find out whether a patient is pregnant, if they have mental illness or use substances. That's because those groups are first of all, it's more difficult to stop smoking for the patients with mental illness and substance use disorder. And for pregnancy, there are contraindications in those cases that I'll mention later. This is the way that pharmacotherapy should be chosen right now, as recommended in December 2016 by the Group of Ottawa. Combination nicotine replacement therapy, that's one patch plus a gum patch or vaporizer, short-acting, is the first choice. Varenicline second. NRT alone, nicotine replacement, so a patch alone or a gum alone. Zyban, bupropion, and then varenicline with nicotine replacement therapy or bupropion with nicotine replacement therapy. In February 2017, the monography on varenicline was changed. So there's a debate right now as to whether combination and varenicline should be chosen equally or should be the first choice in stopping. Once you've chosen the medication and the patient goes on, you have to choose the behavioral support, and you have to get them to get help if you don't give it yourself. You should give yourself some support, but we have a lot of resources available, smoking cessation centers, the line, and we'll talk about that later in the second session. Then there should be follow-up, and that's basically the way to manage smoking cessation. The second key message is smokers may be interested in quitting abruptly, reducing, neither quitting or reducing, but we have to adapt our interventions to their needs. And we go on to the smoking cessation aids. I'll talk about all this. Nicotine replacement therapy, the patch, the gum, lozenge. The ones that have the little red asterisks are the ones that are not covered by the RAMQ, so they're not reimbursed for 12 weeks. The others are reimbursed for 12 weeks, except for varenicline, which is Champix, which will be reimbursed for or covered for 24 weeks. That's about 90% of the cost that's covered by the plan. Now, Health Canada has given a license to Nicoderm in July 17, a new license. And you see here what it says. It's under the Natural Health Products Regulation. All nicotine products are natural products, and they don't require a prescription anymore. And that's since 2007. You see here the dates where licenses were given for the Nicoderm patch. And it's interesting to see what remains in terms of contraindication for nicotine replacement here. Well, first of all, under 18 always remains, pregnancy or nursing. And here, of course, they've added occasional or non-smoker. They're not products for people who don't smoke. And because it's the patch, the problems with skin, whether an allergy or reaction to the ingredients that cause a skin problem. There used to be a list as long as your arm of contraindications, and now what's left is this. Ask your doctor before. So heart, circulation, blood pressure, all that has kind of been put to the responsibility of the doctor. It's sold in every pharmacy, and anybody can get it. So that's a bit the situation. So you can see that we've toned down a lot on the contraindications, with the pregnancy and nursing and less than 18 remaining the ones that are officially contraindications. Now, for experts, there are no contraindications. If you can smoke and take nicotine as a smoker with 7,000 chemicals in it, in the smoke, 60 carcinogen, carbon monoxide, and go on, well, then you can take any form of nicotine to stop smoking and you'll be better off. So for experts, those are the contraindications. If you have problem with the hypersensitivity or problem with the tape of the patch, well, you can't use the patch. If you have cutaneous disease, you can't use the patch. If you have diseases in your mouth all the products that are short-acting, the gum, the lozenge, the inhaler, or the nicotine spray, they all go in your mouth, they're all absorbed through your mouth. They will burn terribly, and you won't be able to tolerate them. Menthol is in the inhaler and in the spray. There were cigarettes with menthol. I've never seen in my life an allergy to menthol, but it's written in the product monographs, and that would be a contraindication. There's a possibility of bronchospasm in asthma and chronic lung disease. Although we call it an inhaler and a spray, a vaporizer, it's meant to go in the mouth, not in the lungs. So if you inhale those products, you may get acute bronchospasm. Now, I carry on with my product license. In July 2017, for the first time, we've been doing it for more than 10 years, but it's the first time that they've allowed the combination of a patch, long-acting nicotine, with short-acting. That is the gum, the lozenge, spray, and all that. And it's also the first time where they've given us the exact doses we should use. They say to start with 21 milligram patch if you smoke more than 19 cigarettes a day, 14, 10 to 19, and 7 if you smoke less than 10 cigarettes a day. First time they've written that. And also first time where they've officially said that we can use the two together. As before, it was always an opinion of expert besides monograph that we could use the two together. They've also, and that was a year ago, they said you could start the patch before you stop smoking. But there was a license given a year ago, about a year before in 2016, but it's repeated here again. And they talk about how to adjust the dosing. And they say that if you have strong cravings, you can continue longer on those doses. And you can also use it for 10 to 12 weeks or longer officially for the first time. They didn't say for life. But for experts, if you can't help but smoking and you have to continue nicotine, we've recommended to patients to go on using their nicotine replacement rather than smoke. And here they've kind of said it in a subtle way. The side effects with the patch is the rash that happens often. It can be very severe and it may prevent you from using it, the patch. You also get vivid dreams and insomnia. And usually the patch gives you a constant level, and at night if you don't remove it, you may get those vivid dreams and you may get insomnia, and you may have to remove the patch at night to help for that. Now this is important. This is showing you 24 hours here, the nicotine concentration in the blood on top of a smoker of 22 cigarettes a day, of somebody who uses a patch of 21 milligram. You can see that with the 22 cigarettes, you're about double of what you have with the patch of 21. That's why in the past we've recommended starting with a patch of 21 with more than 10 cigarettes. It's contrary to what the new license gave as recommendation. And also, if you have the patch and you use the gum that you see here, that's with the gum alone, 4 milligram or 2 milligram, well, you'll come closer to this level that you have when you smoke cigarettes. And that's why we've recommended to use one patch plus one of the short-acting products. But if you have a patient that smokes 50 cigarettes, well, he's on the upper floor here. So even if you have a patch of 21 and you're using those other products, you won't reach a comfort zone for the patient. That's why there are recommendations of using 2, 3, 4 patches, depending on the number of cigarettes you smoke. And I'll show you what the current McGill prescription is for their hospitalized patients later on. All the products that are short-acting, what's written in the product inserts or monographs refer to using it as a therapy alone, as one product alone, and not as combination, which is now what we use. So we don't use alone unless somebody can't use a patch. And even then, we may use more than one short-acting. So usually the lower concentration of gum is used if you smoke more than 30 minutes after awakening or less than 25 cigarettes, because those are two signs of physical dependence to nicotine. The higher dose, the reverse. And there's a maximum that's always set for those products, which really is not relevant anymore. A 2 milligram gum, if used properly with the chew and part technique, will give you about 1 milligram that's absorbed. A cigarette smoke gives you about 1 milligram of absorption. So if you wanted to replace 40 cigarettes in a smoker just with gums, you'd have to give about 40 gums of 2 or 20 of 4. But right now what we do is the patient adjusts himself and he titrates to his needs. He should not feel the cravings, or he should take as much nicotine as he needs. And you won't have those side effects of mouth, jaw pain, hiccups, and if you use the chew and part technique. Now, the lozenge has again recommendation as to what to use for the 1 or 2 milligram. I've written here when they're covered, and by the way, the gum and lozenge are covered by the Régie at 10 a day only. So it's got nothing to do with the need of the patients, it's what's reimbursed. Like there's 1 patch a day that's reimbursed as well. And there were some ways to go to more, but that's not official yet. The Nicorette mini lozenge comes in 2 and 4, and actually the 4 milligram, it's not covered unfortunately. The 4 milligram gives you about 3 milligram absorption, 3 milligram absorbed. So that's the more buck for your money, if you have to pay it, that you get is with this patch. The spray, very useful. 1 spray has 1 milligram of nicotine almost entirely absorbed, so about the equivalent of 1 cigarette. Goes through the mouth, and here they've put a maximum of 64 per day on the monograph, which is kind of inconsistent with the 20 that you saw with the gum or the patch. And here it's almost totally absorbed, so there was no logic behind this maximum that was set. Side effects here, hiccups, hypersecretion, irritation of the mouth. So that's a limitation to using the spray. But if patients get used to it, they get a rush with it because it's absorbed. Within 5 minutes, you've reached a peak of nicotine. This is still deceiving compared to a cigarette because a cigarette, it takes about 10 seconds to get a peak of nicotine. So, but this is as close as it gets, except for the electronic cigarette, to get some nicotine in your blood and to your brain to satisfy your cravings. This is the McGill prescription, which you won't be able to look at in detail here, but it's interesting that if you look here at smoking 20 to 30 cigarettes per day, they recommend starting with a nicotine patch of 28 milligrams, which means 121 plus 7. If you smoke more than 30, they recommend starting with 35 milligrams right off, and then to add on the lozenge, the gum, or the vaporizer. Actually, they even say that if you still have cravings, you increase by 7 milligrams every 24 to 48 hours to a maximum of 42. CAMH in Toronto, which is the Center for Addiction and Mental Health, goes up to 4 patches if you still have cravings. So 4 patches of 21 for, they've not published that anywhere, but that's their recommendation. This is also part of the McGill. It's not published in a peer-reviewed journal because this is off-label. This is off-prescription. It's an expert opinion, but that's what we do if we want to help patients stop smoking. This is the Juul, and it's J-U-U-L, but you've all understood that it's a Juul. It's not a jewel, it's a Juul. This is an electronic cigarette with the shape of a USB key. And those are the pods that contain the nicotine. Twice as much nicotine as any other e-cigarette on the market. It's gained 50% of the market shares in the States in 2 years. And it's ideal to get people addicted. All that to talk about electronic cigarettes. It heats a solution of nicotine. It's not smoke. And it's certainly much less dangerous than cigarettes. The federal government has passed a law. Bill S5 was passed at the end of May, legalizing electronic cigarettes with nicotine. And in its strategy, Canada's tobacco strategy, this is what they say about cessation and harm reduction. They now recommend systematically replacing cigarettes with a vaping product to significantly reduce a smoker's exposure to toxic and cancer chemicals. Note here that it's completely, because a lot of patients who try to stop smoking with an e-cigarette still do the two. They're smoking and they're vaping, and that's not going to achieve a reduction. But they've stated here that it is harm reduction, and adults can access vaping products containing nicotine as a less harmful alternative to smoking. Actually, we asked when they were going to pass that law that they that they not allow publicity to that effect, but they've refused that. So the law was passed, and now there will be commercials a little bit all over the place with e-cigarettes being used as a harm reduction purpose. Now, the worry, of course, is that this may get kids to start smoking and get addicted to nicotine, because mostly with the Juul, you get such a high nicotine level in your blood that you're likely to get addicted and maybe to pass on to cigarettes after, which is not proven. Electronic cigarettes for smoking cessation, systematic review is to tell you it's not proven to be efficacious for smoking cessation. A lot of people have done it all over the world. I've seen patients stop with e-cigarettes, but the proof is not there with randomized controlled trial as it is for the medications. So it's remained a last-ditch effort for patients who have not succeeded with the medications I've shown you and the support before we go to suggesting using e-cigarettes to stop smoking. But now the federal government will promote it as a harm reduction means. I'm going on now to varenicline, Champix, and bupropion, Zyban. Those medications, particularly varenicline, after they were put on the market in 2007 in the States, 2008 in Canada for varenicline, there were a lot of reports of neuropsychiatric adverse events. That meant anxiety, hostility, violence, suicidal thoughts. So much so that there were warnings all over the world. It was even taken off the market in some countries because it was thought to be related to all those events. Now, all the studies that were done on the randomized controlled trials and even huge databases have not shown that there was a causal link between varenicline use or Zyban had the same problem, bupropion in '98, and suicide. So the Food and Drug in the States decided to ask for a big randomized controlled trial to sort that out. That study was called EAGLES, and it was published in 2016. And what they asked them to do is to take a big number of patients, either a group with psychiatric disease, 4,000, or non-psychiatric disease, 4,000, and to treat them with varenicline, bupropion, a nicotine patch, or placebo. So a big randomized controlled trial, follow them for 6 months to a year. And those are the results of the EAGLE study. And those are the neuropsychiatric events, moderate to severe here. Now you'll note, first of all, the drugs were all, they all worked to help patients stop smoking. And varenicline was the most efficacious, more than bupropion, more than one patch. And here they used only one nicotine patch. They didn't use the state-of-the-art combination therapy and the placebo. So they were all, even the patch, they worked more than placebo to get them to stop smoking a year later. In the psychiatric cohort, you can see that there were about 5% of neuropsychiatric events, 5. There's no significant difference in the number of psychiatric events, whether it was varenicline or placebo or any. This was a big surprise because we thought maybe varenicline or bupropion was associated. So this shows that it's really the fact of stopping smoking that does something to make you have those neuropsychiatric events. If you look at the group that had no history of psychiatric disease, it's only 2%. So what's striking is that there's a difference, not in the column, that's also not significantly different, but between the two. They're about 3 or 4 times more. If you have a psychiatric illness history and you stop smoking, whether you stop with a placebo or anything, you have 3 times the chance or risk of having a neuropsychiatric event. Now, the conclusions drawn from EAGLES, the 3 classes can help you stop safely and efficaciously. The neuropsychiatric events occur more frequently in the psychiatric disease group. The findings may not generalize to untreated, unstable, imminent suicidability, or active substance use disorders. They excluded all those patients from the study, which is a shame, because the conclusions apply. Yes? Okay. They apply to only stable psychiatric illness. The Food and Drug in the States has removed its black box. That's the highest warning that you can have about a drug being dangerous following this. And Health Canada has changed the product monograph in February 2017. And I'll show you what's written now. There's still a lot of warnings about the risks. In the meantime, since the beginning of 2018, there were 3 major studies published on the cardiovascular risks of using varenicline. It's called the CAT study. They like animals, it seems, with varenicline. What they did is they prolonged the follow-up on the patients that were in EAGLES up to a year for cardiovascular events. There were no risks of cardiovascular events, which seems that, you know, it was saying that varenicline, bupropion, or the patch, they were not associated with cardiovascular risk. A big meta-analysis, the 4th one on cardiovascular risks on 12,000 patients, also did not show that there were risks with using varenicline and having cardiovascular events. EVITA, a study started in Montreal by Mark Eisenberg at the Jewish, looked at patients who took varenicline who were admitted to hospital for acute coronary syndrome. So this is treating patients with an acute heart attack, contrary to treating patients that have no or little heart disease. It was shown to be safe there. They also showed that after a year, if you use varenicline instead of a placebo, you had a 40% chance of stopping smoking versus 29%. So varenicline works to help those patients stop smoking. There were serious cardiac events in both groups, major cardiovascular events in both groups, but no statistical difference. So it seems from this that it's safe to use it even when you're having an acute heart attack. Now, of course, it seems so nice. Everything is fine now. There's no risk for cardiovascular disease. So this group of Ontario decided to look at the big database of Ontario, and they looked at 56,000 patients who used varenicline between 2011 and 2014. And this database, they matched with the database of admissions to hospitals or emergency room. And they looked at the period 12 weeks before taking varenicline, 12 weeks after. This is the method, self-controlled risk interval design ascertainment. This is a rare methodology to use. It's not a randomized controlled trial. You take the same patient, you look at him before he takes varenicline and after. But the results were amazing for everybody. 34% more cardiovascular events in all participants that went to hospital were admitted to emergency. If the patients had no cardiac histories, was 12% more from before after. And the neuropsychiatric events was 6% more. Those two are statistically significant. The 6% for the neuropsychiatric event is marginally. It's just on the edge of being significant. So those were very surprising results. Right away in the American Journal of Respiratory Critical Care, there was another article to criticize the methodology in saying that there were terrible risks for confounding. If somebody is sick, you're more likely to want to stop smoking. So it seems obvious you may take varenicline because you're already ill. But the results, if you remember, increased the cardiovascular risk, not the neuropsychiatric ones which we were originally worried about. So this is a study that puts back into question whether there may be a risk with using varenicline. This is what the monograph says as of February 17. They tell you that you have to discuss the risk of Champix before stopping smoking. And they really tell you to look into the psychiatric history of patients. You should do that with anybody that stops smoking, because even if they use a placebo or nothing, they're more at risk if they have a psychiatric history of having neuropsychiatric adverse events. They talk about the neuropsychiatric adverse events being reported post-marketing and cardiovascular, and warn you if they have symptoms to get them treated. They still say to encourage friends, family members to watch the patients who stop smoking for changes in mood. And patients with pre-existing psychiatric disorder instructed, if they develop symptoms, to report. And so even though the black box was removed in the States, and in this monograph they do explain the results of Eagles, saying that it doesn't seem to be varenicline that's associated, they still have a lot of warnings. But to me, the warnings should now be extended to the other drugs and even stopping without anything. But you have to remember that Eagles did not cover patients who are not treated for their psychiatric illnesses or who have, are suicidal, or it really was restricted to a group of patients that was stable psychiatric illness. So for those who are not stable, the results of Eagle don't apply. So that's why the warnings are still there. There's also been some problems of seizures. So they say now that patients who are driving car or dangerous machines should wait until they see that they're stable before they use it. And they've added a few more. Somnambulism, difficult to pronounce. But anyway, there was some cases reported. And alcohol-related was increased, the warning, that patients who take alcohol could be more aggressive or have more problems with alcohol. The contraindications to varenicline, which are here, remain. That's not been changed. And the most common side effects, nausea, insomnia, vivid dreams, a bit like with the patch. And you have to remember that varenicline acts on the brain on the same receptors as nicotine. So it's a receptor agonist and antagonist. So it's not surprising that it causes those vivid usual dreams that the nicotine patch causes. You can't remove the patch if you have them here because you take a pill. The dosing has remained the same, where you can either use a 0.5 milligram BID or 1 milligram BID, and you start slowly. What's changed is the quit date. And now, instead of having a fixed quit date, or a quit date 8 to 35 days after you start the varenicline, you can go for a full year and slowly over the full year decrease the amount of cigarettes you smoke. And that's very much in keeping with my first slide that I showed you, where now the quit date doesn't have to be established. You can start the meds and then decide when you're going to stop. So Zyban, bupropion, is an antidepressant. Contrary to varenicline, which is a drug that works like nicotine, this is an antidepressant that works differently than the common antidepressants that we use now. It uses different mechanisms, different pathways. The contraindications here are mostly if you have an allergy to it. You can't use Wellbutrin is also varenicline, and it was the form that was marketed as an antidepressant. Is the same drug. There's also a bupropion, generic bupropion. You can't use all of them together because then you have a high risk of seizures, and this is the most frequent or effect or contraindication is the seizure risk. So if you have seizure disorder, you cannot use Zyban or bupropion. Bulimia and anorexia are eating disorders apparently predisposed to seizures, so it's always been added as a contraindication. You cannot, anything that predisposes to seizure is either a warning or a contraindication. If you're using a sleeping pill or you drink alcohol, you cannot stop your alcohol suddenly because just stopping alcohol can cause a seizure, and you'll be even more predisposed. So you have to stay on your same consumption of those drugs when you use it. Now, those MAO inhibitor drugs are, I think, off the market, the ones that were concerned with this contraindication, but it remains in the 216 product monograph that you should stop thioridazine more than 14 days before you start the Zyban. Now, Zyban has a lot of drug interaction. If you use it with other antidepressants, antipsychotics, you're supposed to decrease the dose, you're supposed to watch. It is a very complicated, much more difficult drug to use than varenicline, which has very few contraindications. This warning about neuropsychiatric events remains in the August 2016 monograph, and I didn't see a new one since the one for varenicline was changed in 2017 following Eagles. This one doesn't seem to have been changed. So basically all the warnings that you heard earlier apply to bupropion as well. Those are the most common side effects. You usually start with a dose of 150 for 3 days. You increase to twice a day for 7 to 12 weeks, and you can even go up to 52 weeks. 12 weeks is reimbursed only. You stop smoking on day 7 to 14. That's in the monograph, but now we've changed our philosophy on this, so you probably could do the same as you do with the Champix. Now, Quebec has invested a lot in smoking cessation since year 2000. Medications have been reimbursed since 2000, the ones that I've talked to you about. We're the only province in Canada that's done that to that extent. Some have now followed, but with much more restricted access. Also, a lot of services have been put through. And I said at the beginning, support is really key. It's not drugs that get patients to stop smoking. They have to believe in it, and there are ways to get to it, but support is essential. So this site, Québec Sans Tabac, will lead you to this little jarrette. This is not yet in English. I don't know why, but at least the jarrette part is in English. And here it really gives you instruction on how to stop. And you have the coordinates of the line, telephone support, the Quit Smoking Center, the Centre d'Abandon du Tabac, which you'll hear more about a bit later. And finally, the text messaging. There's also a site, and on the website, there's a part oriented to teenagers, young adults, and adults. And this texto has been evaluated by the Cancer Society, and it was supposed to be a program for young people. By that I mean less than 24, and finally we realized that cell phones are not used by everybody, so a lot of adults are using it. And what you do is you go on the internet site, you inscribe yourself, and then when you're on your target smoke cessation date, you start receiving textos, and you can ask for help and be contacted by the helpline if you need to talk to somebody. So it keeps giving you motivating messages, and it's been shown to help. So that's another way of helping. And this is, again, to put the emphasis on support. The Quit Smoking Center, the CAT, well, patients are seen. They just have to sign in, take an appointment, and they will be helped to stop smoking. The Quit line will give you counseling on the phone without you going anywhere, but those services are essential to help patients stop smoking. And this leads me to my last key message, which is as much as it takes, as long as it takes, and this is as much for the behavioral support as for the medications. There are patients that probably need to be on nicotine replacement for the rest of their lives. If you're a drug addict or you have a mental illness, it's much more difficult, and you'll end up starting, and maybe now the electronic cigarette with a way of getting nicotine that's less harmful, but not harmless. We're not sure yet of what harm there is in using, even if it's only vaporized nicotine. Well, maybe that's an option for some people. They will have to use nicotine as a drug, a pharmaceutical, or as an electronic cigarette to stay off cigarettes. In Great Britain, they already have 2 electronic cigarettes that are paid by their health services since 2016, and they've got a tobacco company to make it. So it's a bit strange that British American tobacco, or whatever it's called in England, is now making a pharmaceutical. And there's still a lot of controversy about the use of electronic cigarettes, whether it really gets you to stop smoking. And if you use it and you still smoke, well, your risks may actually not be decreased, and it's a false security. So you're likely now with the Canadian government legalization to hear a lot more about e-cigarettes, and it'll be interesting to see how they position it, not only in terms of harm reduction, but of actual smoking cessation. So my 3 key messages are here, and your questions are welcomed. Yes?
I don't know if this is an urban myth, but I mean, I was under the understanding that people who smoke cigarettes have a higher resting heart rate.
I'm not sure if it's hard. It does. Each time you take a cigarette, nicotine and a lot of the other things increase your heart rate and cause vasoconstriction. Nicotine, but it's not only nicotine. When you inhale, it's 7,000 products. And carbon monoxide is one of the worst poisons for your heart. And your carbon monoxide level shoots up. So it's known. You smoke, your pressure goes up a bit, your heart rate goes up. So, but after 2 hours or 2, then your heart rate goes down. So you're...
but if you smoke a lot of cigarettes...
Yeah, well, then you, of course...
Right. So if you're adding nicotine to that, your heart rate doesn't go up again?
No. What happens is that what drives your cigarette consumption is your need for nicotine. We've made cigarettes, I didn't make them, but the tobacco companies, at some point, they decided we'll make cigarettes without nicotine. And big surprise, nobody liked them. Then the maker of Marlboro decided, well, what gets them addicted, and they knew that in the 60s, it's nicotine that makes them addicted. So, so what they did is they made the nicotine, they arranged it so that they put ammonia in the cigarette so that the nicotine is more absorbed. And Marlboro became a hit. Marlboro brand was going down the drain. If you take nicotine with a patch, and studies have shown it, you put your patch on, you don't tell the patient anything, they will just smoke less cigarettes.
Okay.
You give more nicotine, and it's a bit the same with the e-cigarette.
Okay.
You take your nicotine, that's why if you use an e-cigarette, it's got to have nicotine if you want to use it, not to smoke. You know, people used to come in, well, not now, I think it's a bit later, 10 years ago, they would come in and say, use an e-cigarette, but I use it without nicotine. Well, it won't get you to decrease your consumption. If you use an e-cigarette, it's got to have enough nicotine, because then it will fill your need. The Juul is beautiful for that. They use the salt of nicotine, and they've obtained a concentration of 64 milligram per ml in the liquid, contrary to 32, which was the highest with the competitor Blue, a cigarette called Blue. They got the market. 50% of the market switched over. They also have a very cool device, a USB key and everything. But if you use it and you get your rush, well, you're going to carry on using it. You're going to get addicted to it. And that poses the question of, is there a risk? What's the risk of taking this e-cigarette? Although it has mostly nicotine, it is a dilution of glycerin, propylene glycol, has flavors which are supposed to be forbidden in Canada according to our recent law. Flavors can be carcinogens, the flavors that are in those products, because it heats them and it makes carcinogens. A recent study in California has shown that daily users of e-cigarettes, in one of their big national survey, they doubled their risk of heart attacks using e-cigarettes.
Wow.
This information was not available when the government of Canada decided on their law. But they never said it was free of risk, the e-cigarette. They say it's a reduction, so they're less risk. But you have to keep in mind that the e-cigarette certainly has risks. We don't appreciate them yet. Since it has so much less carcinogen, no carbon monoxide, it's less risky. But what the risks are, it makes very, very fine particles that go very deep in the lung. And there have been some reports of fibrosis and lipoid pneumonia and different things. So I would rather my youth not start using e-cigarettes, even though they're going to remain only on e-cigarettes and not graduate to the smoke. I would rather not have them on e-cigarettes, or anybody, as a matter of fact. Yes?
I have a question. In terms of tobacco, when we were talking about just the tobacco leaf,
Yeah.
there's nicotine in the tobacco?
Tobacco leaf, yeah, the tobacco has the nicotine. Actually, even our tobacco replacement products, it's tobacco that's extracted.
Okay.
It's nicotine that's extracted from tobacco.
Okay, so then why are they putting, you're saying 7,000 different products? Why are they putting?
No, they don't put the 7,000. It's
Okay.
when you burn it.
It's when you burn it.
When you
Okay.
burn something, it makes the toxic products.
Okay.
That's why heating a solution of nicotine produces so much less.
Okay.
Now there are new products called Eat No Burn, where you heat a little tobacco cigarette that's inserted in an electronic device to make a vapor.
Yeah.
There are two of those products available in Canada, IQOS and iGlow. Those products heat the tobacco, and they make much more chemicals than heating just a solution of nicotine. They've been trying, the tobacco companies, to get those approved a bit with the law, but the law has approved the vaporizing of nicotine, not those other products, which are likely to be much more dangerous, because although they heat and not burn, it's a tobacco product, not just nicotine, which when burned or heated makes much more of those chemicals, the 7,000 chemicals in question.
The current tobacco that's being used is treated.
That's also bad,
Yes.
because they use all types of chemicals to make it grow better, and they also selected. It's also selected to produce more nicotine. They're hybrids. They've developed strains of tobacco that produce the most nicotine, and they also heat them to make them dry faster, which produces more carcinogens. They put them in those big heaters and heat them rather than heat them in the sun, like used to be done. But anyway, it's when you burn it that you produce the chemicals. So Indian cigarettes, some people say they're more irritant and everything. If you burn, and that brings us to cannabis, and if you burn cannabis, you also produce most of those chemicals. So probably a lot of the risks in burning, in smoking a joint, is the same, although we haven't proven the risks for cancer and heart disease for cannabis. But we've recommended we did for the cannabis law, we sent an avis de santé publique to the government of Canada, and a lot of other people did too. We recommended that it's vaporized, to vaporize the THC rather than smoke it, for the same reasons, because you're much less likely to have risks, health risks, if you vaporize a drug than if you burn it and smoke it. Yes? More?
It's a bit like shisha. From the shisha.
No, the shisha is also burnt.
Okay.
In the water pump, the shisha is the water pump, where it's called narguilé as well. And you usually see it in Tunisian, Moroccan, because it's a Middle East thing. So the big water pump, you inhale, and there's a little container on top where there's charcoal there's tobacco, there may be marijuana, whatever you want to inhale. And when you inhale, it goes through a water tank, and it makes bubbles. So it's called hubble bubble too, because it's it goes like this, and at the end you get a smoke that you don't quite taste as much. So people tend to think it's not dangerous, but it has the carcinogens, it has risks. So this is not a vapor. It's still, yeah, it's a form of smoking, yeah.
So for chewing tobacco, it's not heated.
The chewing tobacco is less risky for lung cancer, heart disease, but it's got such significant risks in the mouth. India is, well, actually, even the one I showed you here, it's interesting that they've used. This is what it causes. It's more cancers of the tongue, the mouth, and there's been a form that's been cleaned of the nitrosamine, which are the carcinogens, used in Sweden. And they've shown in Sweden, where it's mostly males that use the, what's the name of it? I can't remember the brand name of this snuff, but they've been using that in Sweden since the 70s.
Copenhagen.
And yeah, that's a brand name of this product. They've shown a decrease in heart disease and a marked decrease in Sweden. So there's probably there are less risks than smoking again.
Right,
but the risks,
it's not heat release.
no, because it's in your mouth.
But
But
the
there's so
enzymes.
much risk from the contact in your mouth that it's not recommended product.
So what do they do for the gum not to do the same thing?
The gum is just nicotine.
So it doesn't do this.
No, so the gum is not it's not snuff or chew. It's those other products are tobacco that you put in your mouth. So they're not burned, but they still have carcinogens in them. Mostly from the heating in those dryers to dry it quickly. It makes the nitrosamines, which they've removed. Swedish snus, I think it's called Swedish snus. So the clean one had less risks, but still had risks, and that's the one that's been used in Sweden for years. So if you're going to take something in your mouth, you're better off with you have to go with the gum, the lozenge, or the vaporizer, which goes in the mouth too.
Now for the quit smoking, you mentioned that nowadays they can continue smoking with the patch.
Yeah.
How do you control that they are actually going to smoke less while they're having...
You don't have to, they do it themselves.
What if they do both?
It's unlikely, even if they carried on, nicotine, when somebody has been smoking since the age of 12 and he's 40, he's had millions of doses of exposure to nicotine. They're very, very tolerant to nicotine. And anyway, it's been well shown, if you take the nicotine in some other way, you smoke less. Because the drive is in your centers in your brain. So if you take the nicotine by any other way, you need it less. And that's why people go up to 4 patches a day. Even in CAMH, they had, on one conference I went to at one point, they had somebody who I think used 10 patches. Because he needed 10 patches not to get the craving. And because he was smoking so much. Schizophrenic patients, I don't know where they find the time, you'll see patients smoking 4 packs a day. That's 100 cigarettes a day. So if you want to help them, you have to increase the doses. Now the problem is that there are no official recommendations on that. The closest we come, we've seen in the licensed product I showed for Nicoderm. Now they say that you can stay at higher doses longer, but that was for 1 patch. But now you can add as much as you want the other short-acting products. But experts, they go with even higher patches plus the other products. So nicotine is not what kills you. It's everything else that's in the... Now, it may have some effects too. It's a drug, and it does cause vasoconstriction, increases the heart rate. It may have some effects, but it's certainly much, much less than smoking. So, and that's what you have to tell patients. You're better off with that. Can't tell you electronic cigarette is the same, but probably more risk than nicotine products alone. You know, it's the least, that's what harm reduction is. It's not no risk, it's reduction of risk.
For a heavy smoker, do you ever suggest a mixture of Champix, the patch, and like the gum? Or it's only Champix and the gum?
You saw at the end, first of all, in the product monograph of Champix, it's written that it's contraindicated to use it with nicotine replacement. But it's not what experts do. On my first slide, I had the sequence of the drugs being used. One of the last ones was varenicline plus TRN.
But it could be both TRN, it could be the patch and the gum? Or?
Yeah, any TRN. TRN, the difference, the patch is that it gives you a constant level. That's why it's called the continuous or long acting. As the gum, the patch, the inhaler, or the vaporizer, they're absorbed through the mouth. So the fastest is the vaporizer, which is absorbed in 5 minutes, goes to the top, as the gum or lozenge will take up to half an hour. So that's the only difference. So one is long acting, one short acting. The end point is what goes in your blood and what reaches the centers in your brain, the nicotine receptors. And when the nicotine receptor have their fix of nicotine, well, you don't have the craving to smoke anymore. Any more?
Je will say that the pharmacist will say, oh non, c'est trop élevé, 21. On le passe à 14, sinon on va avoir une overdose.
Well, we have to educate the pharmacists. I've spoken to pharmacists a lot, and by the way, the ordonnances collectives are now finished since March 31st. So now it's got to be prescriptions with pre-signed, you know, that will be signed by physicians. Pharmacists are allowed to give nicotine with reimbursement without a prescription being written by a physician. Nurses are, well, you're here to know what your recommendations are. The inhalation therapists are now going to be allowed, just like the nurses, to prescribe as well the nicotine replacement so that it's reimbursed. So that's coming as well. So more and more, and patients can go and buy it, whether we like it or not, but then they'll pay for it. So if they want to get their 12 weeks a year of nicotine replacement reimbursed, they have to go through a physician or a nurse or a pharmacist or an inhalation therapist. Okay, that's it.
Thank you.